let's move into the today as of today today's talk, which is that adenocarcinoma, jumbling of words. Yes, the first line, and with or without chemotherapy. So let's see. We know that lung cancer is the commonest, as on today, high incidence and mortality in all tobacco-related cancers, and it's the leading cause of death and high chance of mortality. But in science, we have progressed huge, and we know that we are able to give a lot of life to many of the people and progress their life. Today, we are going to restrict ourselves to the non-small cell lung cancer. And if you see the lung, that's the classification latest, which has the large cell variety, the squamous cell variety, the adenosquamous carcinoma, the bronchoalveolar, and the pleomorphic, which has the sarcomatoid component. Now, if we are today's evening, we are just going to restrict ourselves to the immunological approach to these cancers, and that's why very important to rule out that we are not missing on any of these driver mutations. Now, these may be differentiated and well differentiated. And if you see just a typical case of non-small cell lung cancer, and multidisciplinary approach is needed. You need a surgical oncologist, medical radiation, and a very good team of pathologists and molecular biologists before you start treatment of these patients. That's a multidisciplinary approach. Yes, scanning also plays an important role for these patients, as well as the PET-CT to rule out metastasis. And this is a very important slide from the 2020, as I've told you, whether it is adenocarcinoma, adenosquamous carcinoma, large cell carcinoma, please do the molecular subtyping. And once you rule out the molecular subtyping, you can see over here PDL1 test is category 1 evidence both in adenocarcinoma, large cell, or not otherwise specified, and even in small squamous cell carcinoma, PDL1 testing in the last of the testing, it's category 1. A recommendation. And if you see the treatment point, even less than anything greater than plus 1% is taken as an indication to treat these patients. So please do a TNM staging. And as you know, the survival rate comes down to almost 10 to 15% as we receive stage 4. And it is very important we do the molecular profiling, and then we take them up for therapy of the cancers. Now, initially, we had only the chemotherapy with us. Then we had the second generation where you combine a platinum with any of the chemotherapeutic backbones. And finally, with the third generation. And now we have got approval with the VEGF with chemotherapy. And also we have got approval of pembrolizumab, either in a single agent or along also to be used along with any chemotherapy background. So historically, we were talking only about a median overall survival of 4 to 5 months, and now we have progressed to around 7.9 to even more than that. So this targeted therapy is what we are very much interested. And if you leave out the sensitizing mutations, because we'll not talk for today's evening, now we will only restrict ourselves to the immune checkpoint inhibitors. Okay, so if you see the NCCN guidelines of today, that is the drugs which are approved is pembrolizumab with carboplatin, pemetrexed, pembrolizumab, cisplatin, pemetrexed, both are category 1. Apart from that, nivolumab, ipilimumab, pemetrexed, or platinum is indicated, and the other impassioned study results of atezolizumab, carbo, nab-paclitaxel, bevacizumab is also approved. So these are the approval, and if you see the heading, it is also an adenocarcinoma, large cell carcinoma, even not otherwise specified. So the whole thing basically forms a single group where immunotherapy has been approved in a metastatic advanced lung cancer. So, and please do not use the other drugs. These drugs are not approved: Benorelbine, gemcitabine, docetaxel, paclitaxel, along with PDL1. So let's move on to the treatment options. If you have a PDL1 greater than 50%, adenocarcinoma, large cells, non-otherwise preferred is pembrolizumab with carboplatin or plus pemetrexed, and it has a category 1 approval. Even atezolizumab with carbo, pacli, bev has category 1 approval. Nivolumab, ipilimumab plus pemetrexed So anything which is greater than 1%, you can use a combination. It can be a single agent immunotherapy, pembrolizumab, whereas you can use it with combination with other two immunotherapy drugs available. So that's the guidelines. And I think that there is a lot of data which is coming in with the CheckMate Keynote fashion study, which supports to the use of in the first line and immunotherapy with the chemo backbone. Now, if you also see in the second line, pembrolizumab, atezolizumab is also approved. And even if there is a good response, even pembrolizumab can be continued into these histopathologies which we are discussing today. If it is a poor performance status, it is better to use a single agent, any of the three drugs, or if it is a good PS is 3 to 4, best supportive care, and in that time, immunotherapy is not what is advised for these patients. Now, let's move on to the, if there is a recurrence, yes, treat the other side along with, you can continue the immunotherapy, changing the without the chemo backbone. So let's look into the pembrolizumab, a PDL1 blocker. Okay, it's approved in category 1 when you have a TPS score of more than 50%, provided your biomarker negative. In second line, it is approved plus as a monotherapy in category 1, and with the TPS score of greater than 1. So that is, as on today, the recommendation of both, say, adenosquamous, squamous, not otherwise specified. So all of them are clubbed together. And PDL1 testing has to be done, and it has category 1. We'll not get into the Ventana. So it's approved in India, can be used to the cutoff more than 1% to be used. And it was seen in the first line, that's the keynote 024. We'll run the slide faster, where pembrolizumab with the doublet chemotherapy and equal distribution, and there is a significant progression-free survival benefit in the pembrolizumab arm. If you see the analysis of the versus the chemotherapy, and there's a p-value is significant with less than 0.001. So pembrolizumab even had an updated OS analysis. So these are some of the graphs. We don't get into details of it, which shows that 3 years overall analysis of single agent pembrolizumab, which is now approved in any of these histopathologies. We did have immunological reactions, but they, including grade 3 to 4, were less common with that. And these are with the chemotherapy. Some of the toxicities were more higher than the chemotherapy, whereas the red bar shows that some fatigue, diarrhea, rashes, pruritus was more common. Even pembrolizumab can be used with TPS score of greater than 1. That is the Keynote 010 study. Okay. And equal arms with having a chemo, there was no difference in the overall survival, but the updated overall survival showed a benefit with a significant p-value almost at the 36 months with 23% and 11%. So again, the pembrolizumab arm did have toxicity, but the grade of 3 to 4 toxicity was much lesser, and outcomes of the patients who completed were reasonably all right. Now, let's look into the IMpower 150. It's because it is important, because atezolizumab and bevacizumab important, because there's two different mechanisms of controlling these tumors. So we had in one arm the immunotherapy, carboplatin, paclitaxel. The second arm had bevacizumab, and the third arm did not have the immunotherapy. And there was maintenance, was either the atezolizumab or the with the VEGF or the VEGF alone. And it has, we'll go to the next place. And if you see, that is the Bev and the carboplatin arm had a definitely lower progression-free survival, where the immunotherapy with the Bev and the CP had a clinical meaningful progression-free benefit, which was improved to addition on a follow-up of 2 years. So, and all these arms, which tells you that there definitely a favor of the arm B, which had the immunotherapy in hand. So this was the overall survival at 24 months, and at 14.5 to 15 months is the median 14.4. Again, there is in favor of arm A, which has the atezolizumab with Bev and the chemotherapy. Okay, so and all these studies, it shows that definitely there was an improvement in the response rate, progression-free survival, and an updated overall survival. There is also some data showing an efficacy in the mutation positive patients, but then we don't bring it for our discussion. Even if you had a sensitizing mutation and had received the prior TKI, the addition of atezolizumab or BEV and chemo increased overall survival benefit in these adenosquamous adenocarcinoma and not otherwise specified, which was not as the not otherwise specified. And the arm B, which had all the three drugs, had a median duration of response almost reaching 1 year, and that was very impressive. Even in liver disease, you see there is a median progression-free survival was 8.2 months. Whether it's with liver mets or without liver mets, there was the two curves definitely separated. And again, the median duration of response was hovering around 10 to 11 months. So now the median overall survival approximately 14.9 months to 19.5 months with the combination arm. So the safety issues, yes, immunological toxicities will be there. All grades were present, but nothing was that severe, which is grade 4 to grade 5. Definitely the forearm had the immunological reactions of like colitis, pancreatitis, pneumonitis was present there. So now, what happens when we use four drugs? The prolongation of the progression-free and the improved overall survival was achieved, whereas the quality of life, the physical functioning was maintained. And despite these subset of patients did receive a little higher treatment-related adverse, which is quite acceptable, can happen at this point of time. So this I Empower 150 met both its co-primary endpoints in phase 3 immunotherapy-based combination and statistically significant meaningful improvement in PS and overall survival when you use in the first line of mutation negative squamous cell. And that combination was well tolerated, and this data supports the wide benefit and of the using of atezolizumab, bevacizumab, and chemotherapy. So that brings us to, I think time limit is only 15 minutes. I have one more minute to sum up. So this lung cancer treatment, the scenario is changing. Now we have into a place where there we are having a lot of options available with us. And at this point of time, yes, we need to give the best to the patients because patients do come asking for treatment. Our pathologist has to be oriented with the new WHO classification of the lung cancer, and that has many components, like how rightly said in the topic, adenosquamous, squamous. There are other classifications which has sarcomatoid subtypes in it, but we do not know what happens when your sarcomatoid subtype is there with the immunotherapy. Yes, molecular testing has to be robust. PDL assessment, particularly with the Ventana staining, has to be done, and the PDL testing has to be compatible with the immunotherapy that we are going to use. And because all the three drugs, nivolumab, single agent, as well as ipilimumab, pembrolizumab, and atezolizumab, all of them has category 1 approval in first as well as second line. And that brings us, and if the TPS score is greater than 50, yes, you are much comfortable of using a single agent immunotherapy, whereas if the TPS score is around less than around 1% or a little more than that, it is advisable to combine with the chemo backbone to give the best benefit to the patients. And I thank you, everybody.